Okay, everyone, good afternoon. My name's Andrew Scopes. I'm a councillor for Beeston Holbeck and I'm the chair of this committee. So welcome you to the Adults Health and Active Lifestyle Scrutiny Board. Today's meeting on the 15th of July 2025. We've got a really important set of things to talk about today. And so we're going to crack on. Just to remind everyone, this meeting, like all public meetings, is webcast, so people can watch live or watch back at a time that suits them. For the benefit of everyone, we're going to start with some introductions. I'm going to start with the board members, if that's okay, and then as other people come in, I'll introduce or ask them to introduce themselves as we get there. So I'll start with myself again. As I said, I'm Andrew Scopes. I'm a councillor for Beeston Holbeck, and I'm the chair of this board. So we'll go round to my left. Thank you.
Stephen Holroyd, council for Ardsley and Robin Hood.
Good afternoon, Councillor Bromley for Horsforth and Rawdon.
Good afternoon, everybody. Councillor Jones from Horsforth.
Good afternoon. I'm Councillor Taylor and I represent Chapel Allerton Ward.
Good afternoon, Councillor Kevin Ritchie, Bramley and Stanley Ward.
Good afternoon. I'm Jonathan Phillips, co-chair of Health Watch Leeds.
Good afternoon, Councillor David Blackburn, Farnley and Wortley Ward.
Good afternoon, Councillor Sandy Lay, Otley and Yeadon Ward.
Good afternoon, Councillor Lynn Buckley, Alwoodley Ward.
Good afternoon, I'm Angela Brogden, the Principal Scrutiny Advisor.
Thank you, everyone, and welcome. I'm going to ask Angela to run through the first 5 items. Thank you.
Thank you, Chair. So in relation to item 1, just to confirm there are no appeals against the refusal of inspection of documents. Under item 2, there are no items for exclusion of the public. In relation to item 3, there are no late items. And under item 4, at this point, please may I ask if members have any declarations of interest in accordance with the Council's Code of Conduct. And I shall take silence as none. Thank you. In relation to item 5, Chair, we do have apologies from Councillor France Mayer and Councillor Gibson, and we have Councillor Jones attending as substitute member. And Councillor Anderson's also notified the Chair in advance that she'll be arriving slightly later to the meeting, Chair.
Super, thank you very much. Okay, we're going to move on to the minutes of the previous meetings. So firstly, in relation to the call-in meeting on the 9th of June, Monday 9th of June, have we got any comments on the minutes or matters arising from that? I'll take silence as agreement. Okay, thank you. And then moving on to the meeting on the 17th of June. Firstly, are there any matters of accuracy anyone wants to raise? So there's one, I can't see anyone indicating, there's one item arising that I'd like to flag, which was is around the developments within the Leeds health system and the NHS. We're going to have a full discussion about it in September with the ICB present. But Phil Wood, who's here today, is also the Senior Responsible Officer, and he's agreed to just give us a 5-minute update on progress on that topic and hopefully answer questions if need be. So Phil, could you just introduce yourself in this context, and we'll come back to you again for the next item as well. Thank you.
Yeah, thank you. I'm Phil Wood. I'm Chief Executive at Leeds Teaching Hospitals, and I'm the Senior Responsible Officer for the development of the provider partnership in place.
Could you just move your mic a bit closer to you, like just bring the whole box closer, yep, and then if you just outline the changes,
okay,
and where we are. Thank you.
Yep. Okay, thank you. So for board members, this is the review was initiated actually prior to, but with knowledge of the impending development around the 10-year plan for the NHS and for development of neighbourhood health, both of which as a place we had been responding to. But it has subsequently become part of those wider structural reforms, thinking about how NHS, local authority, third sector providers will come together to formalise provider collaboratives to then support the government's 10-year plan with its 3 main shifts, particularly out of hospital care. But we've been very conscious in Leeds to ensure that this aligns very strongly with the emerging work around neighbourhood health development, which has been led by the local authority, but with support from ourselves and other health and care partners. In order to aim to have a functional provider collaborative to be able to respond to neighbourhood health initiatives by April 26, we commissioned an external partner to do an evaluation for us of the system, but also to make some recommendations aligned with national policy developments, learning from other systems as to what the architecture of a provider collaborative could look like in the city. We've asked them to look at what's working well now, what's getting in the way of us making further progress, as I said, what other systems are doing around the country, and then some practical examples of how to move forward. In terms of a timescale, ending this week our initial round of interviews with a broad range of individuals from all the stakeholders involved in the system. We have a round table at the end of this week of chief officers where the Value Circle will be presenting their findings and initial evaluations for further discussion. We then move into a 3-month period where they'll be developing for us a recommendation of a roadmap to think about the way forward. There'll be has been some communications out to wider staff across all the organisations, and this will continue over the summer. And this is underpinned by an operational delivery group which has membership from the Council, from the NHS partners, from the ICB, and from colleagues across the partnership supporting primary care in addition. So I think by the time of your September meeting there'll be outputs from this piece of work that will form the view alongside the developing work in neighbourhood health pilots which were announced last week. Thank you.
Thank you very much, Phil. Are there questions from board members to Phil around the sort of the main proposals at this point? Jonathan?
Thank you, Joe. I'm just wondering whether in that work that's going on, you've got the third sector, particularly third sector providers involved in those discussions.
Yes, thank you, Jonathan. So these have been the colleagues have been interviewed as part of the first stage of that. The initial commission was for statutory partners within the system, but Hannah, of course, has been involved as CEO of Health Watch. We have done extensive work to ensure that primary care and the voluntary sector are connected in with the initial discussions, and clearly, particularly around the neighbourhood health aspect, will need to be a critical part of the model.
Thank you very much. If you just turn your speaker back off, Phil, thank you. Can't see anyone else indicating. I appreciate that update, and I think those changes could have profound implications for Leeds, so we need to keep on top of that. Okay, back to the agenda. Are there any other matters arising from the 17th June that board members want to raise? I can't see anyone indicating, and so unless anyone says otherwise, we'll take those as a true record of that meeting. Okay, great. Thank you, everyone. Okay, so now we're going to move on to our first substantive item, which is the QCQ inspection of the maternal and neonatal services in Leeds Teaching Hospital Trust, which is a very important topic to discuss. Can I, just before we get into the discussion, can I just ask the non-members who are sat around the table to introduce themselves? Thank you.
Thank you. Hi everyone, I'm Councillor Fiona Benner. I'm the Cabinet Member at the Council for Equality, Health and Wellbeing.
Hi, Tim Fielding. I'm Deputy Director of Public Health.
Hi there. My name's Ruqayya Mia, Director of Midwifery, Deputy Chief Nurse at Leeds Teaching Hospitals.
Good afternoon, I'm Caroline Barry, I'm the Director for Adults and Health.
Thank you very much. And I think, Phil, you're going to introduce this paper to us. Thank you.
Yes, thank you, Chair. So you've received our summary for board into the regulatory inspections by Care Quality Commission for maternity and neonatal services, and also our participation in the Maternity Safety Support Programme. The background summarises our current arrangements with two maternity and neonatal services provided from St James's Hospital and Leeds General Infirmary, delivering between them over 8,500 babies each year. The majority of that for families in Leeds, but also for those families from the wider region requiring highly specialised and complex care during pregnancy. The neonatal unit at the infirmary is also an intensive care unit which provides intensive care, high dependency care and specialist surgical care for babies from across the north of England, and indeed for some of our services up to and including Scotland. The neonatal unit at St James's is designated as a special care baby unit. Our staff work across both sites and are trained to deliver the highest levels of maternity and neonatal care. At the end of last year, concerns were raised with the Care Quality Commission by a number of families, and this led to a visit from the Care Quality Commission at the end of last year. We have recognised and are deeply sorry that some of our families have been let down by the care they received at the hospitals, and we recognise the need to improve in terms both of listening to the voice of families but also ensuring that we are responding to the medical and other situations that arise. So the paper provides an overview of the inspections and the actions that we are now taking. To summarise those briefly in paragraph 3, the unannounced inspections took place in December for maternity services and January of this year for neonatal services, following concerns raised by families and some of our current and previous staff, and the media reported on some of the poor experiences and harm from families who'd received care by ourselves between 2019 and 2024, with a follow-up article published and broadcast in June of this year. That highlighted both poor patient experience, evidence of a lack of compassionate care from our staff, and our neonatal mortality data from the National Mortality Neonatal Database. As a consequence of that, the regulator, NHS England, held a rapid quality review meeting around our maternity services, and we agreed that we would enter enhanced support through the Maternity Safety Support Programme, which at present has around 36 trusts in the country participating in this programme. We've received a draft report of that, which is being finalised, confirmed for factual accuracy, and will be published, we hope, at our public board at the end of this month. We've already published now in the public domain, and they can be accessed via this paper following the link, the CQC reports. We've also commissioned an external independent review into our neonatal mortality, and we're taking part in a peer review for our neonatal mortality services this week, commissioned by NHS England. Earlier last month, the Secretary of State also announced a rapid national investigation into maternity and neonatal services at 10 hospitals and a national maternity and neonatal task force. We've had no further information, although we are expecting to be one of the 10 trusts that will be involved in that. In section 4, what we've drawn out are the findings and immediate improvements. The ratings for our maternity were rated as inadequate, and the safe and well-led domains highlighted as inadequate in their report. The CQC domains for effective and caring requires improvement. Neonatal services requires improvement overall. I want to put on record that our focus since the beginning of this has to provide assurance to those women currently or in the future using our services that we remain committed to providing safe and compassionate care. And we have had a lot of focus with our staff at all levels to ensure that we are responding to and ensuring we are delivering high quality care to those 8,500 families, recognising that the loss of any individual child is a tragedy. Some of the specific areas following the inspection: maternity staffing and adjusting our midwifery staffing to the birth rate plus recommendations outlined in 2024. And we have an improvement plan which is reporting weekly internally to us around our staffing position. We've also adjusted the types of newborns that are looked after at our St James's neonatal unit. This was prior by arrangement with NHS England, but we have been instructed by the CQC to ensure that only special care babies are supported at the St James's site. This has had implications for the Yorkshire and Humber operational delivery network for neonates because the consequence of the infirmary site being full now means that some women from Leeds have had to be transferred out of Leeds for their delivery because they're not suitable for the St James's site. Another area that we focused a lot on has been the culture and behaviour of our staff in the maternity service and ensuring that our speaking up culture is appropriate and supported. Infection prevention and control was highlighted as not always being safe, and medicines management another area. The immediate improvements you can highlight there include recruiting 55 midwives since last autumn, following agreement to fund these by the Trust Board, and we're currently 11 midwives short of our 367 target. Arrangements around our neonatal unit, as I've outlined, strengthening our midwifery leadership roles, and addressing the freedom to speak up culture, including regular open meetings with myself, the chief nurse, and Rakea as our director of midwifery. We've also been holding family listening and listening events with families who wish to come forward, both those currently using our services and those who have previously used those. We've also taken actions around infection prevention and control and improving medicine storage and management. In addition to that, we're developing an independent maternity and neonatal improvement programme board with an independent chair from outside the Trust who's now been appointed. That will have 6 work streams which are outlined on page 28 on the paper, and these will report through to our Quality Assurance Committee and Trust Board, as well as providing that information externally to NHS England. So I think I'll stop there, Chair. Thank you.
Thank you very much, Phil. So, members, if you want to ask questions, please indicate in the usual way. I'll start, if that's okay. So, I guess my question is around, on the assumption that you were monitoring the quality of care prior in the maternity area beforehand. I guess my question, there's 2 questions that come out of that. So the first one is, what additional key performance indicators are you now looking at as a CEO and as the senior leadership team to ensure that the improvements you want happen? And it sounds like there's something around the amount of staff in there. And the second question that comes out of that is around other areas within the hospital. How can you be sure that it feels like this has come out of the blue? I guess how can we be sure that the monitoring of other areas, including other specialist areas, is also having enough attention to ensure that good service is provided to all patients within the Leeds Teaching Hospital Trust? Thank you.
Thank you. So in terms of the specific maternity improvements, that they outlined on pages 26 and 27, Chair, but also in the action plan that we will submit to the Care Quality Commission. That has a number of key performance indicators, improvement indicators and timescales for improvement that will be reported on a weekly basis at a quality meeting chaired by our Chief Medical Officer and Chief Nurse, and that comes to a weekly executive meeting which I chair. So as of 2 weeks ago, we're now receiving a weekly update with all of the metrics against the action plan that we have outlined. In terms of the question around wider services, we recognise that there is a need for us as an organisation to reflect on this information. As a large organisation which has focused very much on empowering our frontline team leadership, we need to ensure we adopt a culture of speaking up and raising concerns. We use a number of different metrics to ensure our culture is achieving this for us, including our annual staff survey and our monthly review of staff engagement. We also have all parts of our services will go through a monthly assurance process with the deputy executive team, and any concerns raised will be escalated through to the executives. So we are very mindful that we need to ask ourselves very much that question around the risks to reporting for other services, but we've not seen any significant changes in complaints or poor outcomes that we haven't acted upon as a board.
Thank you very much for that, Phil. Okay, I'm going to bring in Councillor Ritchie.
Thank you, Chair. It's clearly been a very dark chapter for the Leeds Hospitals Trust this period, and I want to put on my record my empathy with the families that have been through these issues and affected by them. I do think it's welcome that you've quite rightly apologised to the families, and also reassuring the measures that you've immediately implemented. But I do want to focus on the culture within the service and recognising you are putting in measures to deal with that. You don't go from good to inadequate overnight. So I want more reassurance, and perhaps as part of your review, you look at what has gone wrong with those policies and procedures that you already had in place around culture and openness. For example, the NHS has championed freedom to speak guardians, and we've replicated that at Leeds City Council. So that was already in place. So why wasn't the voices of the staff being heard through that process already? The leadership are cited as being one of the barriers to that negative culture that exists. I can't believe for 1 minute any of those leaders went into the NHS without the values and ethics that we expect in an organisation like the NHS. So what has gone wrong? And can we be reassured that the measures that you've put in, which look resource intensive, will be maintained beyond this sort of period, once you next get rated hopefully back up to good and towards outstanding? And I think Councillor Scopes makes a really good point about other areas. Again, have you got the resources to ensure that the culture within those other areas is gets up to the standard that I expect the maternity to get to after this review or during this review?
Thank you, Councillor. So to respond to your first question, the Care Quality Commission rated our maternity services as good on both sides of the city in June of 2023. So it was surprising that they felt that the rating had moved from good to inadequate in only 15 months. And I think a lot of that identifies the culture, as you rightly identify. We have a Freedom to Speak Up Guardian who has a team of leads and champions. We also monitor from across the whole organisation who is accessing and using that service. We are aware that our maternity staff were fully aware of the freedom to speak up route, but had not used that route, and therefore some of our work on culture, which I'll let Ruqayyah answer in a moment, around why that was the case, I think is something that we're now beginning to unpick. You're absolutely correct around the values, and I'm a firm believer that all staff enter the NHS and other caring professions in order to deliver great care. What I would say is that we know nationally that maternity services are under great scrutiny and great intensive scrutiny, and the Care Quality Commission over the last 2 years has found deterioration across all of the maternity services that they have visited, with very similar themes to those that have been found in ours. There's a national shortage of midwives, both in terms of training and midwives of sufficient seniority and experience to be able to come and work in a unit like ours. That isn't to offer any excuses, Councillor, I think, but it's to set the context of why staff in maternity services feel heavily scrutinised and under significant pressure, which I think we have to recognise can cascade out into poor behaviours and poor compassion in terms of supporting families and patients. We have committed additional resources in terms of investment in staff. I've been to this committee some months ago to report on the disappointing news that our hospital build has been delayed, and centralisation of maternity and neonatal services was a key strategic part of that, which would have had benefit, although does not change a culture in and of itself, but we know that it would have been a more effective way to deliver our services. And as per my earlier answer, I think what's really important for us as an organisation is to triangulate all the information we have around speaking up, around the quality indicators, patient complaints, outcomes of our treatment across all of our services, so that we can provide you with that assurance. I'd like to ask Ruqayyah to come in with some of the detail around the cultural work within maternity that we're currently doing.
Thank you, Phil. So, Councillor, just to say that I came into post in March of this year. I've been a midwife for nearly 30 years at various roles, and I've come into the role at the after the aftermath of the CQC inspection to start the improvement work, and coming in with fresh eyes. I think what Phil has alluded to is that culture that maybe some staff didn't feel empowered. There was a gap of probably about just over a year without the Director of Midwifery in post. There was a Head of Midwifery, as the organisation were looking to recruit best fit. It is changing that culture, that listening, that engagement, that compassion, because that is basics. It's those basic role modelling behaviours. So some of the things that Phil's alluded to is the increase in senior leadership presence, so that monitoring, that compliance and that support to frontline staff is manageable. We've got a split site, that is a factor, and you need to have that belt and brace wraparound that gives you the assurance, not the reassurance. So I have strengthened the leadership, i.e. matron portfolio. I have also increased the next level of leadership, so that key metrics around surveys, IPC, medicines management, incidences get reported, actioned, looked at, so that learning is very quickly implemented. But more importantly, that our staff feel listened to. I spent a lot of time listening to our staff, and with the exec oversight, that we are here to listen to our staff when they feel that something isn't right. And it is that MDT approach that midwives and medical teams are working together. But more importantly, making sure that we listen to, as Phil's alluded to, past and present service users. So I spent today listening to 2 previous families that had sadly some sad outcomes, and I wanted to personally apologise, acknowledge and give the assurance, because trust is a big thing at the moment for our services, to say that we are learning, we need support from our service users to move forward. we don't have any vacancies currently. When this report came, we've recruited, but that's the new workforce from our local system. As Director of Midwifery, it's really, really important that I have wrap around those new midwives, that the right culture of support, empowering, engagement, listening is in place, and I've already got the board's approval to fund a 24-hour model so that our new midwives have that support, that monitoring to deliver good care. Our women just don't want live babies, they also want a good experience, and we have a very diverse population, and we need to be responsive to all of those. But gaining public confidence currently is a lot of time that I spend with my senior colleagues and the matrons to assure and reassure service users. We have a journey to embark on. I feel we've got the right support from NHS England, the MSSP team, and the neighbouring other directors that can share learning. And we've embarked on it because we absolutely have to do something differently. I worked regionally and I worked with the national team previous to coming to Leeds. So these are the tools in my bag to reach out to start that cultural piece. Thank you.
Thank you very much for that. Okay, Councillor Lay.
Thank you, Councillor Ritchie. You've answered most of my questions. That's fine. I was going to ask about culture, but also about the families and the babies that have been harmed, and also about demands placed on the LGI site now. So first of all, I was going to ask whether would you describe the culture in maternity and neonatal services as toxic at the time? Because it certainly feels like that. And I was also going to ask about the leadership at that time. Has there been any remedial work or disciplinary action against any of the leaders that were stopping midwives, by the sounds of things, and staff from raising their concerns? It's pleasing to hear that you say that you're empowering the leadership locally. I assume that means in each unit, in each. What's the oversight for that? Because certainly when I worked at the LGI, there was strong leadership oversight of ward managers. So there are a couple of questions that really build on what Kevin was saying. But I also wanted just to ask, so we say we're listening to families and evidencing that, but it's hopefully much more than just a tick box approach. Have you any early outcomes from you listening to families to what they feel should be happening? And my second question was, have we reached out to the families who were harmed? And I think you just alluded to it. It's really difficult to hear down this end, the pair of you at that end. And I don't know if it's our system, but I'm struggling to hear. But I think you said you'd reached out to 2 families that had been harmed. And are they willing, or are the families that are harmed willing to be part of the new approach to listening and learning?
Thank you, Councillor. So a number of items there to respond to. I think that we have sat down and supported those who were in local leadership positions at the time. The culture of our organisation is not a punitive one, and therefore the issue we have to ask ourselves is how well supported they were in their role at the time, and the pressures that they felt that had led them to the kind of actions that they may or may not have taken. I think a toxic culture is an unhelpful term, but we recognise the kind of unhelpful behaviours that have happened both from midwives and obstetricians in both the units. We have put in place significant oversight of the both maternity unit and neonatal unit leadership, conscious that the key here is to ensure that local leadership feels empowered and has the ownership to make the improvements supported by senior leadership in the organisation. And getting that balance right is important for us. We reached out to all the families that had their names published in any of the media stories to offer to meet. We've met with a number of families who'd had previous tragedies dating back to 2019, but separately for that we're also meeting with current families who have raised any concerns or indeed wish to be part of any types of discussion. I think it's positive that most of those families are willing and have been involved in subsequent conversations around how we can improve our services. And if I were to try to summarise their concerns, it would be that as with often with health and care services, what is thought to be important to the professionals providing the care is not always what is top of the priority for the users of those services. And actually the key thing was to ensure that we're listening to families and actually acting on the issues that they are raising, so that they feel engaged, that they feel that their voice is heard, that they feel that they are contributing to decisions around their care, rather than this being done to them without their not without their consent, but without their sense of being part of the care that they are receiving. I think we need to ensure that whilst every individual case is a tragedy, for which of course we would apologise, but the units between them do deliver 8,500 babies every year, and the vast majority of those are delivered safely and compassionately. And it is helpful for the board to know that we get a significant number of positive pieces of feedback about our maternity and neonatal services provided by the organisation.
Yeah. Can I just ask about the capacity at the LGI? As we're no longer transferring, I assume the babies we were transferring over to St James's was to make capacity either in the maternity wards, the neonatal ward, or special care baby unit. And just to clarify, neonates is still defined as the first 4 weeks, and then therefore they go into a neonatal unit rather than a special care baby unit which takes all the other babies after 4 weeks. Is that how it works? I'm just trying to work out the three patterns, really. Sort of typical delivery, difficult delivery, first 28 days, and then anything happens to a child after 28 days. They're the three levels, are they, or the three departments?
So I think it's probably more helpful to think about babies that are born in our maternity units, the vast majority of which will be straightforward, and mum and baby and family will be going home from the maternity unit. There will be some babies who will be born here who may need a degree of ongoing care that can either be provided in a special care baby unit, which is a level 1, or in a so-called level 2 to 3, which are the neonatal intensive care units. Our infirmary neonatal unit will at any one time be proportionately have newborn babies who have not been born in the hospital but have been transferred into the hospital to receive specialised care for liver, for heart, for a whole variety of other conditions. Our previous practice had been, in order to create sometimes the capacity to transfer in one of those babies, we may have needed to move another baby across the city to St James's if their clinical condition allowed it. The challenge we currently operate within now is that if a baby with a significant heart problem needs to be transferred from anywhere in the north of England, we may have to not be able to take that baby because we cannot create the capacity at the infirmary because of the limited ability to transfer babies across the city.
And how are we are we working to rectify that? Because obviously it suggests that it's just about equipment that the CQC closed the transfers of some babies. If we provided the equipment at St James's, would we rectify it?
So we previously had an agreement with NHS England that because our staff rotate between the two sites, that we could have limited use of more clinically unwell babies on the St James's site. It is important to recognise that we have no other children's services on the St James's site, and therefore our ability to do that is limited. We are clearly working now on how we can create more, potentially look at the creation of more capacity at the LGI site, both for maternity and neonates, but clearly we have no empty estate, and without the funding for the hospital, we have no funding in order to be able to create that additional capacity. So that's a challenge for us at present.
Thank you very much for that. Okay, Councillor Bromley.
Thank you. Again, it's just sort of following on really from the questions that have been asked so far. It's kind of tricky to believe that whistleblowers wouldn't originally at some point try to raise their concern, or at least express it in a way that was visibly observational, even if not directly taken to some form of management. So I think I understand that you said there always has been this speak up champion sort of role. It just wasn't, people weren't aware of it. So, I mean, essentially you're either saying that they were too exhausted or too tired to have the time to say anything, or that when somebody did say something, it wasn't taken really as a complaint as such. It seems a little bit blurred around, and I'm sure you can appreciate that it seems blurred. I do really welcome the fact that you've got a clinical background, and so I think that's really helpful in looking into the reflections and the points that are being raised. And I also do want to sort of add on that I saw a news article on social media going over this subject, and I think that there are a lot of positive stories to tell too, and there are a lot of people that obviously wanted to jump on quickly to say that they had positive experiences, and for people and families and women that are pregnant right now not to feel scared. And I think that is a really important factor to have. And I assume that the NHS doesn't have money to spend on bots putting comments underneath these. They are real stories. So it's just the part of, do we have any understanding that there was a blockage of some kind that isn't just about awareness, that there was a blockage, and are we saying that is totally really down to the fact that there wasn't enough midwives? And then secondly, if we are transferring so much extra work now to the LGI, how can we make sure that their speak up champion is definitely made aware of, and that any complaints and worries they have, just because they don't necessarily have something coming externally to our knowledge, they definitely have an environment that doesn't have these concerning problems? Thank you.
Yeah, thank you, Councillor. So in terms of speaking up, we know it's a challenge across the whole NHS, and the reason that staff don't speak up we know is complicated. We are aware that staff did raise concerns with layers of management, and that wasn't escalated through the organisation. And the reasons for that, I think, are complicated and probably not for this forum. But we are working with that layer of management because, of course, as the accountable officer, I have to reflect on why those managers didn't feel they should escalate those issues through the organisation, and clearly we have to understand that issue as well. So I think our staff both felt that they may have raised issues and then nothing had happened, and therefore stopped raising issues, and we know that that can be a problem in all NHS organisations. Or that the decision by managers at a local level was that the issue could be dealt with without the need for further escalation. I'll bring Ruqayya in a moment perhaps to comment further on that in terms of how we are ensuring that the LGI site does not itself become overwhelmed. I think we had already taken steps in place to ensure that, as far as possible, mums with more straightforward pregnancies and delivery were the ones that were booked in to deliver at the St James's site, and any more complex, because, for example, the mother had an underlying health condition or problems with pregnancy, we'd already made arrangements that they would be in the delivered at the LGI site. So out of that 8,500, it doesn't split 50-50 between St James's and the LGI. We already deliver more babies at the LGI, and the more complex babies go to the LGI. The bigger challenge, as I answered in the previous question, is more around ensuring that as a regional centre for very sick newborn babies, we can continue to have the capacity at the LGI if a baby needs to be transferred in, and we are having to work harder to do that. And as the consequence can be that a mum with a straightforward delivery who may have been booked into St James's is having to be transferred to another local maternity unit in order to have their baby. Those numbers are small, but it's not ideal if you live in the city of Leeds that you have to deliver your baby elsewhere. Rakaya, would you come in on the issue around our speaking up culture?
So, and I think you've described it really well. How do staff feel that they can speak up? So I've spent in roles being a freedom to speak up guardian and as chair in various roles. It's a really hard one to gain staff's confidence to be able to speak, but it's also the leadership, and I'm talking particularly around maternity leadership, to encourage that culture, embed it, role model it, because staff want to be able to be heard. So all I can say to you is, in the short time that I've been here, it was that element of trust between the multiple layers. I think is probably the best way to describe that staff need to feel supported, staff need to feel listened to, and they need to see tangible actions. So I've alluded already to strengthening the leadership, because that can be a challenge. So each site now has a designated leadership stack. So you've got your matron, you've got your deputy, and then overarching is me. But it's also that collaborative work with our consultants as well, because we don't just work in isolation as midwives, but it's all the neonatal element. So to keep a baby safe requires all of those elements, and a mum to be safe and heard. So the leadership manageable element is strengthening that matron, that team leadership, that deputy leadership role, and having that regular walkabouts engagement with staff so they feel safe, that they are part of the solution rather than being done to. I think Phil described, and I think that's a really excellent point. So as Director of Midwifery, I am at that level where I am visible, and I think probably that wasn't as visible in the past, shall we say. And it was around capacity as well, because it isn't just about having a lot of midwives if the culture isn't right. So it's a whole different approach coming in with fresh eyes, I guess. And I don't intend to be defensive, but I see experts on the shop floor really wanting to do things differently, and that is my assurance. But in my role, I have to continue to do that and get that granular culture right through the right workforce, building those blocks with the foundations with the early careers, but that engagement with the execs so that they have full oversight and I can keep going and saying, well, I need this, I need that, is really, really important. So I feel that we've started that journey, and the engagement with the families is the thing that really, really reassures me that, we are apologising, we are recognising that we need to do things differently. I know I'm waffling on, but I hope it makes sense what I'm saying, because there is that leadership, accountability, support and monitoring.
Thank you. That sounds really reassuring, to be honest, and like a sense of groundedness in the understanding of what it would actually take on the shop floor, which I think is really important for any organisation ever, and especially when it's obviously such vulnerable situations as well, life and death, that it oversees. I think you touched on empathy, fatigue, which is such a real thing, and I think doesn't often get talked about enough, where, like, as a carer and in the managing positions of this, they're still carers, really, even if it may not be directly. And that empathy fatigue is such a huge thing when everything is completely overwhelming and feels completely unfixable. So are we in a position now where we think that the managers there have the level of support they need as well, so that they are able to bring empathy in the decisions that they're making too?
Well, I think you're absolutely right. I think empathy fatigue is a real challenge for the health and care system. And I would probably add to that the individual regulation of healthcare practitioners is another sense of vulnerability that staff can feel over anything that might go wrong in terms of their own professional practice. What we have done is, as Rakaya has described, strengthen the intermediate leadership layer. That's a team that will report to the chief nurse and the chief medical officer, so they're receiving that support on a weekly basis to be able to really support them to deal with a lot of these challenging conversations and difficult conversations to hear with staff and families on the front line. So I think we have strengthened now the sense that managers caught in the middle, as it were, have got an outlet through the organisation, which I think they always had, but perhaps felt that they didn't want to demonstrate their own vulnerability or capability by needing to seek help from more senior managers. There's a fine balance, as we all know, between where you find yourself in terms of your own capability and seeking help. But I think we have put strengthened intermediate support in place to allow those managers to get that support as well.
Thank you very much. Okay, Councillor Taylor.
Thanks, Chair. All my questions have been asked really by Councillor Ritchie and Councillor Lay. So I'm just going to take you back to page 26, 27. I'm going to leave culture because there's so much about cultures. You talk about infection, prevention, control, and environment wasn't safe at the time. And there's so much going on. Midwife, medication didn't handle or store safely. But then when you look back on 28, it says our doctors and nurses, they are qualified expertise. And go back again, you mentioned that there wasn't feel like they could report on other staff. But we all have a duty of care. And you mentioned that they're 100% for the babies. We listen to those that speak out. What about those who haven't got a voice? Are you reaching out to those that haven't got a voice? Do they know where to go to? So you have done quite a bit since being here. But previous to you coming in, are those frontline workers who would not listen, who would not report it? Are they still in their jobs? Is it a clean slate from top down to wiped out everything? That's it.
So you've talked about safety culture, I think, if I've heard you right. So around the monitoring, you need people on the shop floor, which I've discussed, and the leadership, because that's that whole chain of command, and compliances around understanding the key metrics is, because you've got to have enough people in senior leadership to be able to do that. So that's in place, I feel. I think I'm just trying to remember the other half of your question.
So the other part was just about voices that are hard to hear.
Yeah.
So underrepresented groups and
people
who find it hard to speak up. Thank you.
So that's the other piece of work. We do have a consultant midwife for equity, and she already had a team. And having worked with her in the time that I have, I feel reassured and assured that her values and her focus is right. I've strengthened that team, and we've recently had a diagnostic, haven't we, from NHS England to give us more added assurance and guidance on what we need to do differently. I also have that background, and it is reaching out, you're absolutely right, to those families and those birthing people and women, and that piece has already started, because they're the ones that probably wouldn't speak out that need to speak out. So you're absolutely right, and we are on that journey already. Because as I say, the team has expanded and we're putting those strategies in place to capture the voices of the communities. Because I believe very much in the asset-based approach to our services going forward. And out of the current position we're in is an opportunity to do things differently and engage our entire communities and those voices that will shape our journey going forward, is the short answer. Thank you.
Okay, thank you. I'll leave it there. Thanks.
Thank you very much. Okay, Councillor Jones. Come in, yeah.
Apologies. I was just going to add to that it's worth noting that our maternity services, both by the Ockenden Review in 23 and the Care Quality Commission in 23, were commended for the work they have done with different ethnic populations in the city of women whose voices aren't always heard. So it is something that we've recognised for a long time, and the team has actually done some very commendable work and continues to do that with those groups.
Thank you. Okay, Councillor Jones, thanks for that, Phil.
Well, thank you. Thank you, Chair. Well, first of all, I'm glad that you are working with the people who've been involved with this. My concern is, and I understand that CQC is a snapshot to some extent, I understand that, but when I'm looking at the report, it says prior to our visit we received a number of concerns from staff, people using the service and the families about the quality of care being delivered. During that period, were you not aware of this? Because I'd find that very difficult. I'd also find it difficult to move from where you started from 15 months before to where you are now. Was nobody actually aware that there was a deterioration in the service? Or are we saying that the CQC's original report gave you a better mark than what you expected? Is that so? It's either one or the other. And what I always find disturbing with the NHS is the constant movement of staff doesn't lead to a constant view. So when you're moving staff constantly, and I've dealt with the NHS as a trade union official, the constant changing of staff doesn't actually always get to the problem. That concerns me quite significantly. So my real question is, during that 15-month period, are we really saying that you were unaware that there was a deterioration in service, or do we accept there was a deterioration in service? If that is the case, what actions were taken during that 15-month period? And Sandy's done me for the rest of the question, by the way. Thank you again.
Yes, thank you. So it will be more straightforward with the benefit of hindsight to go back to the 2023 CQC good rating and question about whether that was an appropriate rating or not. At the time, the CQC were instructed by the then Secretary of State to do a rapid set of assessments of as many maternity services as was feasible, and ours was given a good rating. I think as an organisation we have to take at face value the rating the regulator gives us and the reports that they provide. There were actions required within that report from 2023 which we undertook. They were reported through to the Trust Board, and the information received by senior management at the time clearly did not provide sufficient detail for us to recognise that there had been changes within the service. I think that the rating system for the CQC in some ways is less important than our recognition that within that 15-month period, the question we need to ask ourselves is whether senior management up to board level and myself received the level of detail and assurance that we required to have confidence that what we were seeing represented what was happening in our maternity services, and clearly we'd acknowledge that that wasn't the case when we received the report. In terms of moving staff around, our frontline staff have not been moved around. They work on both sites as explained before. Most of the leadership that was in place over that time remains involved with that, and our approach has been to try to ensure we support and develop those leaders to be better leaders rather than replacing them with others.
I find it very difficult to believe, and maybe being very cynical, that during a 15-month period there's a deterioration that senior management would not be aware. Because if that is the case, I would question how capable senior managers are, to be absolutely honest. Because I would expect if there's a deterioration that will be picked up.
Thank you, Councillor. I think that one of the reflections we take from this is what organisations are receiving in terms of the assurance about the quality and safety of their services. And in terms of the quality and safety of services, in terms of outcomes, deliveries, harms, incidents, there were no changes between those 15 months. What clearly had deteriorated was the culture within the maternity unit, and that is something that as senior managers we were less aware of.
Thank you very much for that. That is helpful. Okay, Jonathan, next.
Thank you, Chair. Some of what I was going to say was picked up before in relation to when a maternity unit is maybe not working quite as well as it should be, then people with health inequalities, be that around their ethnicity, disability, orientation or whatever, are likely to come off worse. And you've acknowledged some of the expertise around dealing with that. So I'd just like to highlight the fact that in March, West Yorkshire Health and Care Partnerships via Healthwatch did a report around health inequalities and maternity, which actually highlighted some really good practice in Leeds, but also came up with 10 recommendations to focus on around making sure that maternity services really are good in terms of recognise the needs of people with inequalities. So I think if you haven't looked at that, it will be good to build that into your improvement plan to make sure that you've considered those recommendations and decide what might be relevant to Leeds. The other thing I wanted to ask, separate to that, is whether you could say a little bit more about the independent chair of the improvement panel that you've appointed, and how you're going to make sure that that person is genuinely independent in terms of being able to report without fear or favour, and how they might network in with other things that are going on in the city, like the Leeds Maternity and Neonatal Voices partnership. So if you could say a bit more about that, that would be very helpful.
Thank you ever so much, Councillor. So
I'm not a councillor.
Have I appointed?
Co-chair of Healthwatch.
So just to say that the 10 recommendations that you're talking about, we will be addressing those as part of the consultant midwives portfolio, and we do also have a dedicated obstetric, in fact 2 consultants very keen and interested in progressing this. We've refreshed and started writing our health inequalities strategy, which does start at grassroots. It's about that listening, engaging. I think that is absolutely at the heart of all of the midwifery and the obstetric focus as we transition and realign. That fits into the 6 work streams that Phil referred to. There is 2 types of board. One is the regulatory assurance, which is looking at the key metrics, quality, safety, and that's already started from the time of the inspection when we were aware that we needed to do this. So that's already in progress around quality, safety, and ensuring that the basic granular levels, clinical details and support is available. Talking about the wider engagement piece will be picked up by the Transformational Board, the independent chair who has been appointed as a Director of Midwifery external to our organisation. And each of those work streams is focused around reducing inequalities, workforce to name a few, and then it's the stakeholder engagement. We will not have all the answers from the lens and the perspective of the NHS. We need our communities, we need the national team, and we need expertise regionally, nationally, but internationally to come and inform some of our practices. For example, digital solution, but also looking at our diverse platforms about the language line and those advocates that are in place. So that is already being worked up, and we have already drawn onto those expertise. But for me as Director of Midwifery and as a Deputy Chief Nurse, where my reporting is directly to the Chief Nurse, is something very different. And I can say from my experience that doesn't exist in a lot of systems. So that is something that is showing the absolute priority of the maternity and neonatal agenda. And that really will give us the independence and the objectivity to be able to drive that change in partnership with co-production of our communities, because it isn't just us saying this is how it should be, but listening to those voices and weaving that into our health inequality strategy. But that engagement's already started, and it is the early days as we start to fact find and build it going forward with our communities and partners.
And if I may add, around the question of the independence of the chair, as Rakay has said, that this individual is from a midwifery background and has done similar work elsewhere. We're also part of two external programmes, so the MSSP and the Quality Improvement Group through NHS England, and our independent chair will have a direct connection to those two external programmes, as well as overseeing the work inside the organisation.
Thank you very much for that. Okay, I'm going to bring in Councillor Anderson next. Could you introduce yourself, because you weren't here earlier, and just to be say that if it's questions that were asked before you arrived, I won't allow them, but hopefully that's understanding.
Yep, no, that's fine. I was sorry, I was late today. I'm Councillor Caroline Anderson. I represent Adeline Wharfdale Ward. And apologies if this already has been asked, because I was late in arriving, so I accept that if it's already been answered, you can just say we answered it earlier. The top two bullet points on page 28 of the report regarding immediate improvements. So for the benefit of those listening live on the web, they are improving infection control and cleanliness by having a greater presence of matrons on the wards, increasing the visits and inspections in ward areas, and replacing damaged furniture and equipment. That's the first one. Improving our medicine storage and management with a full stock audit and comprehensive checks implemented. Can you tell me why that's not the norm in a unit? Why does it take a CQC report to point that out to you?
Thank you, Councillor. So, I think at any point, a snapshot inspection will find issues within a busy clinical area. There wouldn't be a clinical area across the entire NHS where all of these things would be 100% in place. And CQC themselves, as other regulators, would acknowledge that they produce a snapshot report at a moment in time. However, we take on board the issues around ensuring that our matron presence is strengthened, and Rakaya has answered that with our new leadership structure across both sites, which includes their ability to increase visits and inspections across ward areas, and the furniture and equipment replacement has already been done. I think we would have to understand, we understand that some of our staff had raised a request around replacing the furniture which had not been actioned, and that's a part of our review as to why that had been left, so that CQC could see that level of damage. The management of a full stock audit and comprehensive checks, our medicines management team would rotate that on a regular basis across the whole of our organisation. Again, the issue can relate to the timing of any inspection and visit. We are not in a position with our medicines management capacity to have a permanent full stock audit available, as all of this still requires manual stock audit checking, because we do not have an electronic medicines management system in the organisation.
I don't entirely accept that, because furniture and equipment doesn't just break down on the day that CQC happen to come round. the full stock audit and comprehensive check, there must be some kind of checklist that's kept beside the medicines which says the last time that that audit was done, so they could see when that was last done. So
thank you. It's a really important question, and as a clinician and a clinical leader, I would absolutely agree with you. It goes back to the culture piece we discussed earlier on, that leadership oversight. So you will have missed that I'd come into post from March as Director of Midwifery. It's that whole accountability, that monitoring process. The Trust already has a well-embedded monitoring process that reports centrally around IPC metrics, around the medicines management. How that feeds in culturally in terms of the leadership within maternity is the bit that I'm working to align. And yes, you are right, it shouldn't have happened, but I have replaced all those chairs. We have ordered them to say that there is no room for complacency and acceptance that IPC are absolutely critical in any NHS organisation. So I have undertaken that urgent piece of work, and it is already in place, and it shouldn't have happened, you are right, but trust-wide monitoring processes were in place, and that complex culture probably was a reason why that it wasn't where it needed to be at the time, but it is in place. Thank you.
Thank you for that. Can I just clarify? So, just what you said, Phil. So, one of the recommendations, the last bullet point on immediate improvements, it does say, and this is from the CQC, saying improving medicine storage and management with a full stock audit and comprehensive checks implemented. When you say having a full stock audit isn't possible, do you mean that that bullet point isn't being adhered to, or could you just expand from my understanding?
Yes, what I mean is that it's incumbent for both the staff working within the unit and the external medicines management team to ensure that a full stock audit is undertaken on a regular basis. I think, as Rakaya has outlined, what we are working on is to ensure that staff feel they still have the capacity and professional responsibility to undertake their part of a stock audit.
Thank you. Okay, so normally I let each councillor have one set of questions, but I'm going to let Councillor Lay have one more short question on this topic.
Thank you again. Sorry, me again. I just wanted to ask about the midwives. Firstly, like others have said, I would like to place on record that I think midwives do a very difficult job under immense stress and strain. We know that midwifery is short of thousands that we need in this country, and that workload on a unit can be very destabilising for midwives, and so I just want to place that on record that I still think midwives do a fantastic job. But accordingly, you've recruited or will done by September 90 new midwives. 35 of them, you say, are newly qualified. Well, everyone knows newly qualified nurses, not nurses, midwives are going to need support. I don't know of the 55 that you've recruited so far, how many of those were newly qualified, but let's assume a number of them were. Are they getting the support that they need? Because the last thing we want is midwives leaving in droves like sometimes we feel teachers are.
Thank you ever so much, and thank you for acknowledging the challenging roles that midwives have. So to answer your questions around the 55, they wouldn't come all in one go. They'll be staggered. And we have a number of support in place, or had previously, the professional midwifery advocate, what used to be supervisory. So that was already in place. And since then, it's actually 38 newly qualified midwives. And out of that, it'll be a total of 40. And the other remaining 2 will be experienced qualified midwives. One of the challenges that Leeds has, and Leeds is a place I have always looked up to, a centre of excellence, is that people come to gain expertise and skills, And once they've gained that, they go home to where home is. So you will always have that element of attrition that we have to work against, because people relocate once they've skilled themselves up. So that's something that is the workforce plan for me to work on. Regarding your point about the early careers midwives, the newly qualified, the 38 that will be coming in is absolutely integral that I do the wraparound, which I alluded to earlier on, which is a preceptorship model that other hospitals outside maternity units have adopted, what is known as a preceptorship model. And this is a 24-hour, 7-day model that I'm implementing with a view to giving the wraparound shift by shift, day by day, so that those midwives get the hands-on skills training from the supernumerary protected Band 7 senior role. And that is what we need to do. We need to support, strengthen, upskill our midwives so they have the confidence to be able to deliver care, listen, engage, and ensure that they're working in partnership with our women, birthing people and families. So that model is coming into effect, and that's something that I will start to build more and more. So that is one area, and those midwives will start to stagger in from September, November to October, and then I'll start to look at the other models that I need to implement, and that is the advanced midwifery practitioners, so that we can do the granular quality safety piece about normality around birth and what constitutes good experience, and that women are listened to truly and have that experience breastfeeding and all the other ongoing support. Thank you.
Thank you very much for that. That's really helpful. And I think we've got to the end of the questions, so I'm just going to make some comments and ask for the board's support. So I think there's quite a lot we've gone through, and I really appreciate your time and your being honest about the situation, need for improvement, and the challenges that you've faced. I think it'd be first point I've got. It'd be really helpful if Jonathan, you send your 10 recommendations from Health Watch to Angela for the board to see. I think we should be aware of those as well. I think the second thing I think is that we, subject to the board's approval, I think we'll want sort of updates from you, Phil, particularly around staffing, and particularly if improvements aren't on pace with what you're hoping and your board are expecting. And given that you're having weekly updates, we'll expect a timely update if those fall behind. And then the third thing I think is worth saying is that this point about capital funding in terms of the LGI, I think that's a really valid point you make, Phil, and that does make it really difficult in terms of capacity. So I know that the council has written to the Department of Health about this, but I do think it's worth writing again, raising these concerns that there does need to be, in my view, capital funding. So those are my points. I'm going to bring in Councillor Blackburn if you've got any other comments that you want to make in terms of what we should be doing as a board on this.
Okay, so thanks, Chair. I think it's important that we do get updates, but get very regular updates. It's no good waiting 3 or 4 months. I think certainly next meeting we have, which will be 2 months off now, won't it, because of holiday, we need to report then, because quite honestly, something needs doing rapidly. I haven't asked any questions because some of our learned colleagues here know more than I do, so I've been listening, but we need to do something.
Yeah, thank you, Councillor Blackburn. Yeah, in terms of the watching brief, I'm not necessarily. My view is that we don't necessarily need another formal meeting, but we do need correspondence from Phil in terms of assurance to say we're on track. That would be my take. So those were my 3 points. Are the board happy with those in terms of moving forward? I do think they're important. Okay. Do you have any other comments to make, Phil, before you go?
Well, no, I mean, thank you, and thanks for... I think it's important that we've come to talk to you and appreciate the questions and challenge that councillors have rightly given us around improving our services, listening to our families, and ensuring that we can provide safe and compassionate care. And just to assure the board that as an organisation, with the support of our external partners, we're absolutely committed to doing that.
Okay, thank you very much. Okay, so with that, I'm going to close this item and we're going to move on to item 8. Just be probably a 30-second break while the guests for the next item come to the table. Thank you. Just for those watching at home, board members are just getting a cup of coffee, so just give us another 30 seconds. Okay, so let's move on with the meeting if that's okay. Our members can hear everyone and they can come back as we go through. So our two new guests at the table, could you introduce yourself first? Thank you.
Hi everybody, my name is Catherine Ingold. I'm a consultant in public health and chief officer.
Hello, I'm Emma Hardy. I'm a registrar in public health.
Yeah, so thank you very much for coming today. This is a really important topic, in my opinion. So do you want to just introduce your paper? That'd be great. Oh, Councillor Venner, do you want to... Sorry, Councillor Venner, you can...
No, it's fine. I'll just make some really brief comments and then pass on to Catherine and Emma to do a more detailed introduction. So this paper was requested by the board to look at young people and the impacts on health and well-being of smartphones and social media. I have to say, I don't know about anyone else, I found it absolutely fascinating. So thank you very much. It's a really, really interesting paper, and I think what comes out to it really clearly is that because this is still a relatively new world, it is an emerging picture, so we don't fully know what the impact is on children and young people of smartphones and social media. I think, though, what does also come across is that there are both good and bad things in children's engagement with the digital world. And I always felt that when I was working in my previous life as a mental health practitioner, working where I work with both children and adults, that to take mental health as an example, there's some really horrible stuff online in terms of, like pro-suicide, pro-self-harm, pro-anorexia websites. But there's also a huge amount of self-help resource, community, connectivity and comfort that can be found for people struggling with mental health problems on the internet. So I think it's always had that ability to be both really positive and really empowering and really informative and potentially damaging. This is veering into safety rather than health, but I think I used to think about this a lot when I had the children's portfolio, when I was the Cabinet Member for Children's Services, and thinking about how adults protect children from the online world. And I thought the most interesting thing in the adolescence programme drama was where the police officer was going down completely the wrong route of investigation because he didn't know what the emojis meant and thought that a child was liking and being friends with another child, and actually there was a whole meaning behind the emojis which his son had to tell him about. And that was really struck me, because that was the one thing I worried about more than anything else in terms of online safety when I had the children's portfolio, was the fact that as adults we don't know what we don't know. And so how do we protect children who are always going to be ahead of us in terms of the way they communicate, the language they use, whether it's pictorial like emojis or the actual language. So I think that's a really interesting thought about how we as adults keep children safe when they know more than we do a lot of the time. I wanted to end positively though. One of the primary schools where I'm a governor, we had a governor's meeting last week, and they were talking about how the school did a screen-free experiment as a school, where they had a day where they didn't use screens at all in school. The children were telling teachers off for doing things like the register online, and they were like, no, I'm only doing this and then I'll come off it. But they carried it on to home, and children were so positive and so happy about their experience of a screen-free life. And I think campaigns like Screen-Free Childhood are really gaining some momentum, and children themselves will often articulate how positive it is not to be attached to a screen. The other thing I wanted to feedback is that when I chaired the Corporate Parenting Board, the Care Leavers Council members complained to me about counsellors being on their phones in the meeting and not being present and not listening and not engaging fully with them. And I thought that was, and so I then was quite strict with counsellors in the meeting about their phones, and I think it's really important to remember that as adults, we are equally attached to our phones. I'm always horrified when my phone tells me how many hours I've spent on the screen. It's always like 5 times more than I think it is. And I think it's really important to remember that we are role modelling we are role models in this world, and we need to look at ourselves as well as looking at the risks and the harms potentially in relation to children. So thank you.
Okay. Thanks, Councillor Venner. Really helpful points. Because it's quite a long paper, we've just prepared a few short slides just to summarise what's in the paper and start off the discussion. So we were asked to pull together evidence around children and young people's use of smartphones and social media, the prevalence, the impacts and policies, things that we put into place to make a difference. So in terms of prevalence, smartphone ownership is near universal by the time children get to high school. 95%, so the vast majority of teenagers use social media. Echoing Councillor Venner's point, most 10 to 15-year-olds spend over 3 hours a day online. Interestingly, smartphone use is increasing rapidly amongst preschoolers who are the children of the first generation that had smartphones. On the next slide, in terms of impacts, again, as Councillor Venner said, there are harms and there are benefits. And I think when you think about social media, you think about all the horrific things. But actually, one of the biggest things is the smartphone use replaces real life interaction. That's a huge thing that came out when we were looking at the literature. There are concerns around developmental delay in children, disruption of sleep, the mental health harms, issues around cyberbullying and exploitation, and the fact that that can go on 24 hours because your phone's in your hand, and exposure to harmful content. But again, there are benefits. So benefits around skills development, support for some marginalised groups, safety and independence, and maintaining friendships. So we were asked to think about what could happen. So there are examples in the paper of different approaches from different countries. I really like Finland. Finland are ahead on most things, and I think they are on smartphones and social media. We've got the Online Safety Act from 2023 that comes into force at the end of the month, which imposes significant new responsibilities on social media platforms to protect children. Most UK schools have implemented phone bans, although the evidence is inconclusive about whether that makes any difference. And there's work happening in Leeds already, training for staff, responding to their needs, disconnect to reconnect weeks, There's a lot of work, as you will hopefully know, in Leeds around play and creativity, and also National Society of Prevention of Cruelty to Children listen and learn sessions, which are described in the paper. In terms of challenges, again, Councillor Venner has touched on this. Proving definitive causation of harm is really difficult. The evidence base around this is not solid. There are many factors influencing children, young people, today. The research is limited, and the online world is changing rapidly. And also, commercial interests are at odds with harm reduction. Social media companies want to kind of hook you in and keep you on your phone longer than you realise. We've suggested in the paper that this conversation, it's brilliant that the Adults and Health Board wanted a public health view on this, but we need to widen the conversation to the Children and Young People's Partnership. We need to listen to children and young people and families, the Children and Family Scrutiny Board, who are aware of this paper and have seen it, the Deputy Director of Learning for Children's Services, Chief Officer for Education, Head of Service for Learning Access, the lead for the Leeds Play Strategy, Youth Services, the 0 to 19 Public Health Integrated Nursing Service, Children's Centres, Early Help Leeds, the Health and Wellbeing Service in Leeds. They're the service that deliver personal social health education at school, children's public health colleagues and colleagues in public mental health. All of these colleagues have got a stake in this work. So the last slide really includes the recommendations that we've come to a conclusion that are important things to think about. How best do we listen to children, young people, families and teachers to understand their perspective of the harms and the benefits of smartphones and social media, and what would help them? We need to include a really large emphasis on more unsupervised play and childhood independence to counteract the kind of passive use of social media. Copy in Finland, we need to increase media literacy education for children so they can critically appraise social media content and they can recognise fake news. The Online Safety Act has provisions in to remove harmful content, but not to fact check and truth check content on social media. So that's a skill children really need. We need to raise awareness of online harms with children and young people, but also ensure they know where to turn for support if they've had bad experiences. If something bad has happened, it doesn't mean that it can't be undone, which I think is taught a lot. You know, if you do this, this picture will be there forever, but there are things that can be put in place, and not everybody is aware of that. Offering training for staff who work with children and young people on online harms and how to support children and young people so that they have that knowledge as well, and also to ensure that social media companies comply with the Online Safety Act. So that's a whistle-stop tour of what's in the paper, and I'm interested in hearing where the discussion goes.
Thank you very much for that very comprehensive summary of an even more comprehensive report. Yeah, I think it's a really interesting conversation. I think the challenge around so I very much differentiate, like the report does, between the internet generally and social media, and that's because of the monetization of the social media firms, which are encouraged to they make more money by you being on longer. So they try and make it addictive. So that's really helpful. And I like what you said about the need for wisdom. I don't think there's any way to possibly fact check everything, because statistics are used, as Churchill said, lies damn lies, and then statistics. So you can use them to justify your thing. I'm going to bring in people, and then I might ask some questions if mine haven't been asked. So I'll start with Councillor Blackburn.
I don't know if anybody else has seen this, but there's a graph in the papers, and what amazes me here is it says 3% of children between 3 and 5 own a smartphone. Well, when my son was between 3 and 5, all he wanted to own was a Milky Bar. You know, so it amazes me, and I think what it should say that they've got access to a phone, and it's the parents that are buying it, and that's where we've got to look. But I know you tried your best to put together what you can, and evidence is not necessarily there. But I certainly like to see some work done on how it affects children's mental health. That there's something wrong in our society, in that we're having mental health problems more than we had done. And, you know, you go back, sort of my father's generation that were brought up in depression, where they were under much more stress than we are. And then what happens when he's a young man, we have a world war, you know. And they didn't seem to have the same problems we have. And we've got to look at what's causing that. And I've got to say, some of this is sitting on your own. I mean, we get it. We're on this computer. Our 2 hours a meeting yesterday afternoon on my own in office. We're nobody there to talk to, and it can be soul destroying. So I think we've got to look at ways we can do that. But I've got to say, I find it quite quite good, this report. But as I say, I still say I can't see how you can have a few percent of 3 to 5 year olds buying mobile phones.
So I didn't quite catch the question in that. There wasn't one. I'm just giving Councillor Blackburn an opportunity to ask a question.
The question is can't we do anything to try and establish mental health consequences, basically?
Sorry, I pressed the wrong button. Thank you. I'm going to, before I forget, just come back to the distinction between children having access to a mobile phone and owning a mobile phone. And I completely agree. Obviously, the 4-year-olds didn't buy it. Their parents can take it away at whim. But those numbers were children who had their own mobile phone, as opposed to children who just had access or used a parent's mobile phone. So it is not their own phone, but it is disquieting. That's just the number who had that child's mobile phone that belonged to them, as much as their bike or their chocolate bar belonged to them. I don't want people thinking that that's the percentage that have access to a mobile phone, which is way, way, way higher and in there somewhere. And regarding the increase in mental health, I probably can't answer your actual question fully. I wish we could, but it does. My understanding when I was researching for this is that the number of mental health diagnoses in children has been going up a lot over the last 5-10 years. And there seems a mixed picture as to the cause. It seems maybe there is some true incidence and a lot of mental health, depression, anxiety, maybe things like autism and neurodisability. But also there's a lot more recognition of symptoms amongst children, amongst doctors, amongst parents, and a lot more people coming forward for diagnoses. So I can't answer as to the causes, but from my reading, there is some true increase and some increased recognition of things that maybe wouldn't have been diagnosed 10 years ago.
Thanks, Emma. And to add to that, like we don't always need to pathologise mental health. It's about how people think and how people feel. And we've got really excellent data in the city from the My Health, My School survey from 2009. And we know from 2009 the proportion of children feeling happy every day or most days has gone down consistently, and the proportion of children who feel stressed or anxious on every day or most days has gone up. So we know that social media has impacts on mental health in terms of social comparison and self-esteem, body image, sleep disruption, exposure to harmful content and self-harm risks and cyberbullying. We know the impacts that you've kind of mentioned really about socialisation and loneliness and lack of social connection and lack of play and lack of physical activity caused by screen time. But we also know that children, they have lived through a pandemic and they have lived through lockdown and cost of living crises and environmental catastrophe. So there are many, many factors that influence children's mental health. But we also know there are many protective factors. And I think that's important that we focus on how we can protect children and young people's mental health as well as we can.
Thank you very much. Okay, Councillor Holroyd.
Yeah, I think it's a really good report, but I think we do all appreciate that until the big corporations take responsibility for the damage they're doing to kids, it's going to be very hard for us to counteract it. But I think one of the things that does concern me, I think we need to look at how we can educate parents and responsible adults, like the use of, is like Councillor Venn has already pointed out, the use of emojis on social media. To us, it might be a smiley face and a thumbs up, but I think it's quite clear from certain things that have come out in the media and TV shows and things that to children they're a lot different. And I think we need to look at how we educate parents on how they can prevent if they're going to allow their young children to use mobile phones and smartphones, how they can protect them with the different software that's out there and things. And I think one of the concerns I have is how interactive schools are becoming and how reliant on technology schools are becoming. Because I think I'm of an age where we used to go home at the start of the school year and back us school books in wrapping paper and things to make them pretty, whereas now they've got laptops and tablets in schools and interactive whiteboards. And I think I think we need to be encouraging our schools, like Councillor Venner said, to have days where they don't use technology. And I think we need to be teaching children that not using technology is also a good thing. Going out and climbing a tree and playing in a field is a good thing. And I think this report just backs that up. But I think we need to be looking at using this report to look at how we educate children and adults that playtime doesn't have to be sat on a screen. And although screen time is great for education and a lot of the games are educational, there's better ways to do it.
Do you want to comment? It's mostly a statement, but you're welcome to comment. Yeah, it's hard to ask a question because, but one of the things I did want to do was have a debate about this, because I do think it is an emerging theme which has been said a couple of times. But if we don't, as a health board, talk about the health implications of emerging themes, who else will? And so I think there's a space for us to just give statements. I think that's really helpful. And what you said there, I think, is something 100% right, that there's something about parents and carers taking responsibility for the young people. And so I was talking to someone recently, and their school, there's doing this voluntary thing where they wouldn't allow certain apps until a certain age, because there's a point where we as a council, we can't mandate stuff, but we can try and educate parents. I don't know if you want to comment, Catherine.
Yeah, just to say, I am aware some primary schools do bring in I think they're ex-police to deliver sessions to raise awareness. So I think it's a very good point. I suppose it kind of echoing Councillor Venner's point around the emojis. We'll never be ahead of what children know. So I don't think we'll always know what an aubergine means or a peach, but they're the only ones I know. But I think the thing is a culture of openness and trust and not blaming and talking to your children. We can't control children, but we can be brilliant parents and listen to children, and so they can come to us when they're worried about us and educate us. So I think that would be the evidence-based line we would need to go down in that area.
Thank you. Okay, Councillor Bromley.
Thank you, and I really appreciate this being brought to the board, really important topic. And I have a 17-year-old at home, so this is part of our conversation. And I really love your answer there in terms of it is really important for us to be like as clued up as we can be, but the whole point is that they want their own culture. They want to feel a sense of like identity that's different to ours. And so I think in terms of like this hawk mentality, and also that sense, that older generation of where either you shut up and don't talk about it, which actually has created a generational issue, or the fact that it was a sense of you must tell me the truth, which who tells someone the truth just because you've been told to tell somebody the truth? So one of the elements, because we are having a generational change with parenting, aren't we? And the way that children have their own autonomy as well, which I really, really welcome, which has obviously then created a sense of speaking out and talking about issues as well, which doesn't mean that people used to handle it better at all. Actually means that we have a generation that is able to acknowledge, which I hope then means that by the time they're in their 30s, they're going to be doing way better than we are. But we're yet to see, right? And we just don't know, and that's the problem. We're always living with the moment and the time that we're in currently, which makes it really hard to then completely analyse, unless all generations were just stagnant and always stayed the same. In terms of exposure to technology, I really recognise that we don't actually know in terms of children having phones at school or not, whether that is a positive or a negative to how they think it. And I really welcome that open understanding, because I think right now what we're doing is praising schools that have taken them away, but in actual fact we haven't got the evidence to show there that is the case. And if we're doing this with a really authoritative element of just going no and yes to young people, are we actually still then creating still part of the same problem? The other part is I read an article about how as teenagers there's always been a threat, no matter what generation we look at. It used to be rock and roll, but there always used to be an element of what are these young people being exposed to. And I think that we can't just look at things constantly as always taking away the risk. We need to look at how do we teach the next generation how to handle risk. And one of those elements that comes with the play strategy is, and it creates obviously away from technology, but exposure to risk, exposure to how do you find your way across if you miss your bus and you need to get back to somewhere. And the reliance on technology has been something that we've brought in as a safety element. In actual fact, it's taken away an ability to take risks at times. And I think that what we see with the element of anxiety is a sense of younger people feeling like they need to rely on something and not their own intuition or trust in their own sort of ability to manage something. I'm not sure if there was a question in that, other than that I'm really, really pleased that this has come about, and I really enjoy this conversation and debate. And my daughter would be way better on the board to talk about this today, to be quite honest. But yes, yes, I think, thank you for coming here today.
Yeah, thank you, Councillor Bromley, really helpful comments. Very, very helpful comments. I think there's a space for us all learning in this together, and hopefully end up somewhere better than we are. But you're right about every generation had a risk, and I guess the fear I have is that if my child is out and their battery runs out, they're stuck, and you don't want them to be that dependent on the technology. Councillor Taylor?
Thanks, Chair. Mine is going to be short, and it's not a question, it's just a comment. I really love the report. I love what you want to do, and I would love to be a part of this. I've got grandchildren, and I'm at council. We can't educate them. And for you to go further with this, we need to take parents with us, because we will be teaching them this outside, but they go home. My grandkids come to me for every third Sunday, and there's a box at my kitchen door where they have to put the phones in, and no one to have a phone for that duration. And one played trick, they have another phone, and they keep disappearing. So what I'm saying is, I monitoring at home, and I'm telling them we need to have a conversation. But when they go back home, it's not like that. And I know moms give phone to their kids, even babies. Even babies just looked at it to get on with the days. So I'm afraid this is going to be a challenge. If we are going to do it with kids alone, we need parents and board, because 3 years old, where do they get a phone from? Even 5, 6, 7, where do they get a phone from? So parents need to take that responsibility. And I love Councillor Venner, because I haven't been back on the phone yet, Councillor Venner, attempted. But but I do love it, and I just think it's a good conversation. Mental health is not just phone, we know that. It's today's society with young people, but this contributed as well. Yeah.
Thank you, Councillor Taylor. Okay, Councillor Ritchie, and Councillor Taylor, can you just turn your microphone on? And then Councillor Ritchie, do you want to come in?
Thank you, Chair, and thank you for your report. Clearly, you've put a lot of work into that, so appreciated. I was shocked by the numbers, or the percentage, of 3 to 5 year olds using social media, and just wondered if that included them actually having accounts, or if it's just using parents' social media. I've got a question on age verification, which I know Australia are implementing robust age verification. Do we know why the UK isn't doing that now? We've got, I think, pretty robust age verification on sort of betting gambling sites, which are probably easier to implement because that's 18 and things like bank cards probably linked to that. But I would have thought that would be something that we should involve ourselves with or get delivered. And then in terms of the research, how long do you think it will be before we start to have those high quality longitudinal studies that are lacking at the moment, and will that be utilising any lessons learned from the measures that those countries have put in, for example?
Thank you. 3 to 5 year olds, they're not using social media. They're gaming and playing on screens. That's what they're up to. The age verification, that is a requirement of the Online Safety Act. So those rules, the Act was from 2023, but the rules begin on the 25th of July. So in 10 days' time, social media companies are required to have robust age verification checks. And that's supposed to be like a really huge change. And the idea is under 18s won't be able to see pornography, self-harm or suicide material, and providers will need to remove harmful content from their websites. So critics of the Act say it doesn't go far enough, and as I mentioned before, it doesn't require removal of disinformation, but that is a big change that is coming in, so we'll need to wait and see what happens. In terms of robust research, it's a good question. I'm not sure we'll ever know. I don't know if you've got a view, or Emma's got a view on this yet.
I'll chip in firstly with the first question about the children on social media. It is mentioned in the report. It's fewer than the children gaming. It's on the Ofcom report, which is linked, and I can send a copy over when I find the right bit. From memory, 20% of those children are using social media independently, as in without their parent even having, sitting on their lap doing it with them. And the others is a mixture of children having their own social media account, which the parents kind of run with them, or children using the parent's social media account. So there is further breakdown on those figures, which I will dig out and I can get over in whatever the right way is to do that. Because it was shocking, but this was longer. This was longer than 40 pages, and that's one of the bits that got the chop. I apologise. Regarding the research, my take is that the sort of timeframes to get good quality research, to get multiple good quality long studies, where by nature you're there to look at the exposure at what happens, and they're 5 years or 10 years later to see the outcomes, and you have multiple of those to put together. I think by the time you have that standard of evidence, the game will have changed. And I think that it'll be interesting to look back on, and I'll be sure there'll be things to learn, but I think everything will be as different in 10 years as it was 10 years ago, is only my personal opinion. So I think we need to consider what is appropriate to act when we don't have that certainty, because we might never have that certainty about the effects of what children are doing right now in this instance. If you want to add anything.
No, I support what you said.
Excellent. I have support.
Yeah, well, thank you. I did read social media. It's on page 36, 3 to 5 year olds, 39% in 2024. So I'm glad I read the report right, and you confirmed that. So these age verifications that are planned in the UK, because it did seem distinct in the report that Australia, it points out the robustness that just seemed, because there's one thing, isn't there, to having an age verification of 18 so that you can't view pornographic material, but actually things like signing up for a Facebook account at 10 years old or whatever, although I understand from the report that Facebook's not the thing, but some of the others have got 13 age restrictions. So it's those things. That's what I'm seeking, really. Is it as robust in this country?
My understanding is that no, even to be on Facebook, and it's in the appendices somewhere, most of them have a theoretical age cut-off of 13, but in practice, the vast majority of children have accounts before that age. It's not robust. I think the Online Safety Act should look, is looking to limit what types of content children can access, but I don't think it will make it more difficult for children to get on social media. I think it more will discourage the social media sites from having that harmful content available on them, is my understanding. So it's not as robust as what they're doing in Australia, and it won't stop them having access to social media.
Thanks for that. Okay, Jonathan, next.
Thank you. I must preface what I'm going to say, which is this is not a Health Watch position, because Health Watch doesn't have a position on this. But it's just my thoughts, like you, as a grandparent. And what I think has been positive about this discussion is that I think the underlying theme is we've got to go with the grain on this. And working with young people to make sure that their use of it is safe, much as we do with making sure that driving is safe. And conversations I've had with my grandchildren, most of them using it, is one of them said they wouldn't have survived COVID without their mobile phone because it allowed them to keep in touch with their friends. One of my grandchildren is deaf. And the use of his mobile phone and social media allows him to keep in contact with other deaf children, not just around the country, but around the world. And there are so many positives, but there are also those dangers. And it seems to me that some of the discussion, not in the room here today, has been sort of verging on a moral panic around it, a bit like you were saying about there's one in every generation. And I think in whatever we do in Leeds, we need to avoid that moral panic. And you had a list of the people to work with, and young people seems to me absolutely at the top of them in terms of they're the ones that have got the solutions about how they can use it, but be safer. And a lot of them are very well able to use it and be safe. So there's a group of people that are extremely vulnerable around it, but lots are mature, I think, and manage it and avoid the risk. So that feels to me to be the way to go.
Thank you, Jonathan. Okay, Councillor Jones.
I'll make the confession, I've worked on a computer since 1977. So that's and I've probably used it every day since, to be absolutely fair. Makes sense why you like doing. I asked for that, didn't I? Thank you. This report is absolutely excellent, but I think trying to stop what's going to come in the next 10 years is extremely difficult. I also suspect, no matter what you do with age verification, kids will find their way around it. They're smart enough to do that, and you can go around in circles with that. But what will be interesting is where we are in 2 years' time with this. I think that will be an interesting piece of research, but I suspect that some of the figures will change significantly, and some of it won't be better, but some of it might be better. The example what my granddaughter uses a computer for a smartphone for, is to talk to her mates, and that seems to be a normal thing. She does occasionally go on TikTok, but it's mainly about talking to her friends. So I think that's not quite in here. I think that's something, because now I think one of the problems we have is that we all live in wider, our friends are wide apart, and it's a way for us to keep in touch with people. I think that's something that's not in here that probably needs to have a look at. But the report is absolutely excellent to us, and well done.
Thank you. Councillor Lay.
Thank you. Yeah, well, I don't think I've got a question either, but I might have. It might come out of one. I think certainly we have to keep it in perspective, I think. Councillor Bromley, Emmy's right. Teenagers have always been impulsive, they've always been risk takers, they've always had mood swings, they've always been emotional, and that's because the frontal cortex doesn't fully develop and hardwire until they're 25. The most important thing is to get your kids to 25. If you can get your kids to 25 without harming themselves, then they suddenly they stop being Kevin and Perry and they start being nice people. Yeah? So it's really difficult, isn't it, when I've got a 20-year-old son and he just spends his life on his phone. But then I also work in A&E and I see everything from babies right through to old people. And they're sat in that waiting room. Toddlers are on pieces of electronic equipment because without it they would be bored. I also know that many parents will use it as a form of babysitting. It's much easier just to put Peppa Pig on your phone and say, there you go. And then I also see lots of teenagers sat there on their phones, but also counsellors and everybody else. We're all just as bad, yeah? We used to sit there with newspapers and comics and various other things, and we now spend our lives, unlike Councillor Venner, every week I see my online, you were on for that amount of time, and I think I must do something about it. There's balance to be had, I suspect. Nokia are selling 1 million phones, I think, a week at the moment. That is just... It doesn't have Wi-Fi. It is to allow parents to know that your child has got a mobile phone and can, in an emergency, or make calls, etc. But it's a really pared back phone that isn't smart in any way. It is just that traditional. Yeah. No, of course they don't. Of course they don't. But you could at least mandate that for preteen kids. For preteen kids, it's going to be difficult with teenagers, I think, or kids in high school. And I read once, we've also become a society where they call the generation before they get to school the bred in captivity generation, because as parents we've become reticent to create the risk and allow our kids. I walked to infant school. I can remember walking to infant school. Okay, I accept that there's less traffic and all of that, but the harms were just as great, I think, from abduction and that sort of thing. And now most kids are either driven to school, primary school, or walk to school or whatever, and then we give them freedom in high school, and suddenly they go from having no real sense of freedom to being given all this freedom, and I find it really difficult. I found it really difficult with both my daughter, who is now 27, and a lovely, lovely woman. She was a rotten teenager, yeah. But fortunately, my wife dealt with that. I went to work, and my son, and challenging them and saying, "I want to see your phone," because I also believe that, like Wurzel Gummidge, for those of you who can remember, in the 70s or 80s, we all have different heads. So I act differently at work, and I act differently at home, and I act differently down the pub, and my personas are different, almost like I'm taking one head off and putting another one on. So my children will tell me what I want to hear, and then bloody well do something completely different. And how do you overcome that without locking them up? Huh? Yeah. So my question is... I don't have a question because I don't know the answer. But there has to be balance because, as has already been said, we can't control teenagers, and electronic devices have a lot of good going for them as well. It's managing the harm and the increase of harm.
Thank you for that, Councillor Lay. I'm going to let Councillor Bromley come in again.
That's actually really good, like now leading into what I wanted to say as well. So the original part of what I wanted to comment on was that I predict, I'll put this on screen, that we'll see a generational trend to move away from technology. I reckon they'll become like a movement because they'll be so up on well-being, and the more information that comes out, they'll start making it sort of a trend to move away from it and have time away. But yeah, get Botox instead. in terms of for the headaches, I think in terms of looking at risk, I do get really worried when it comes to technology in terms of Snapchat and devices where the ID location of the person at the other side of the screen seems really loose and like sketchy when it actually comes to being able to trace them. The amount of, I mean, I won't even go into, but the conversations I've had with my own daughter in terms of the conversations that have come up on that and how many that she's had to report is scary. Like that just seems to be an absolute, like, you know, stranger danger situation, whereas ordinarily, you know, just walking back and forward to school that we actually think is risky isn't the risk. Going back to what Sandy was mentioning about parenting, I do think that there is something that we can do when you mentioned it before about trust and creating a level of openness where they can come to us, and it's an approach I've had for a while, but I don't necessarily find it easy because I wasn't brought up that way, so I find it tricky. But it involves biting my tongue a lot and not responding in a way that feels like the automatic, you know, reaction to things. But what it has meant is that all of those conversations that have come about that she's been worried about on social media, she's come first to me because she wants to talk to somebody that might have more experience in the world around to navigate it, and then we navigate it together. But my first part of conversation is, I trust you, and I want to be there for you, but I also trust in that you want good for yourself and you want good for others, so I believe in you in that. So as and when you're ready, come to me. And it meant that she wants me to track her phone. She asked me to do that, and she asked to put on 360, and she asked for all these things, but she asked for it for her safety. But in actual fact, I don't like it because it makes me more anxious than if I did. So I think openness and trust and finding this new dynamic that we have with the next generation is part of the answer to these things too. Or if it could be, that would be amazing.
Super, thank you very much. Those really helpful comments from everyone. I think a couple of things that I'll reflect on. There's something about the using technology for childcare, which isn't really a social media thing, but I do think that is a concern, and I think that's sort of an aspect where there's a health inequality issue, and there's something in the report as well around sort of those who are least well off tend to use the mobile phone the most, and so I do think as a city that wants to reduce health inequalities, we do need to think about that dynamic, which is really hard to do. I think there is more research done by the social media giants that isn't in the public domain, and I sometimes wonder if in the future that will come out and be a scandal, but I can't predict the future. And then the other thing that I think is worth reflecting on, which we haven't really talked about, is the silos that social media can sometimes generate. So you like a certain thing, and then the social media brings the same type of stuff on your screen, and then you end up in a world where you think everyone thinks these things when that's clearly not the case. And I think that goes back to, again, the educational aspect of understanding why the machine is giving you the stuff and the content that it is. And I think for me that's one of the most worrying things about social media, is that you end up in a world where you think everyone thinks this thing, which is either not true, or it's a perspective, or it's an opinion which isn't held by most people. And then you meet someone who has the other side of the social media chain, and you can't even talk to each other because you don't know how to talk to someone who holds a different view, because you just block them rather than having a conversation like you'd have to do in real life. So I think those are my additional comments. It feels to me like, in terms of going forwards, I think there's something around us as a board passing this on to the Children Young People's Partnership as a report and saying, look, we've been thinking about this. Can you think about this as well? Because I do think there's a partnership approach that has to be done. And then I think the other thing we need to do is ask public health to think about how they can push forward some kind of like the educational piece, because there is a point, we've talked quite a lot about educating parents and carers, we've talked about educating young people, and I guess the question is, what does that look like? Who's responsible for it? How does it happen? What context does it happen? And so I think there's probably some thinking to be done there. I don't think we can solve that here today in a way that is doesn't just beat the drum of one perspective, because I think there is something about, even in this, there's a range of views in this board in terms of what to do about it, but there's a wider range of views out in the real world. So I think that, I guess, in terms of the public health perspective, that's the bit I think you guys can take away. And in terms of the passing it on, does that make sense? Is there anything else board members would like to add? Taking quietness as agreement. So that's really helpful. Thank you. So, Catherine and Emma, I really appreciate your time, and as you can tell by the comments, everyone's read your report and has appreciated it and understands the nuance, which I really feel like you've gone out of your way to make sure is in there. So thank you very much for that. Really appreciate it. So with that, I'm going to close that item. Right. We've been going for over 2 hours, so I think we should probably just have a 5-minute comfort break, and then we'll go to work schedule. As I said in pre-meet, there is something that we do need to talk about in the work schedule, so it will probably take 20 minutes or so. So just going to have a 5-minute break, and we'll come back at 1:45, if that's okay. Thank you. to the work schedule item, which is item 9 in your meeting papers. So firstly, I'd just like to highlight the work schedule, which is printed in your pack. So we'll just start by asking any questions on the work schedule. Or are we happy to go along with it for the time being? I take... Jonathan, do you want to come in?
Thank you. I just had one thought, which was that there's the changes to the NHS and what's happening around the ICB scheduled for September. But with the kind of change that is being talked about, I just wonder whether it would be useful for the board to have an update on that March. I know there's quite a bit in the March meeting, but otherwise, by the time it's rescheduled into the new municipal year, it's going to be June.
Thanks for that. Let's have in September. We'll have a think about that, because I don't think it'll fit in the March item, but we could have a working group either in March or April, which might just be informal.
Yeah.
It won't be. It'll be a meeting, and we could do it on Teams or something. So let's see where we feel in terms of progress. But you're absolutely right. There's huge changes. Thank you.
Thanks.
Any other comments on the work schedule? Councillor Ritchie?
Yeah, thank you. Yeah, and thank you for including the 2 items that I brought to the table. And I just think it's really important that we get the right people around the table in terms of witnesses. Obviously, the current providers being one of them for the latter, the deaf-blind communities, but also service users as well. So we've got a few organisations in the city, and hopefully they'll be brought to the table. And yeah, that's it really. I'm sure the B&Me strategy is being worked on anyway. But keeping, as I said, we're going to keep oversight of it here. I think that's important.
Yeah, thanks for that, Councillor Ritchie. I'm a big believer in outside witnesses, so I think you're right to do that. In terms of contacts, I'm sure Angela will be in touch with you, and if there's contacts that we don't have, Angela's nodding as well. So thank you, Councillor Ritchie.
Yeah, I mean, officers should be able to provide all the organisations. I mean, I'm happy to look at that, but I don't think it's my job to identify those organisations.
Agreed, thank you. Okay, anything else on the work schedule? So I can't see anyone, so we'll stick with it as it is for the moment, and I agree with Councillor Ritchie in terms of witnesses. So the extra thing I just want to talk about, which is I think it's really important for us to keep an eye on, is that when the executive board papers were published, there was a published deficit for the adults directorate. Obviously, that's one of the very large budgets in the council, and being on budget is an important thing for us as a council, given our financial constraints. So I thought it was appropriate for us as a board to have early sight of that and give the director an opportunity to set out why we are where we are and what's been done about it, and us to have an option to ask questions at this early stage. I think this is the earliest point that we possibly could have. So thank you, Caroline, for coming today and agreeing to give us a sort of position, and then I'll ask sort of respond to questions if there are any. So over to you. Thank you.
Thank you very much. So you will see that in the appendix that it does talk about the adult social care and the overall adults and health budget. So the adult social care net budget for 25-26 is £199.48 million, so just under £200 million. It doesn't include the public health ring-fenced grant, which is a baseline of £53.48 million, plus an additional amount of £11 million for specific funding for rough sleepers, for drug and alcohol services and the like. In addition to our base budget, this year, for the current financial year, we have a savings requirement of £36 million to be delivered, and we're delivering those, we're identifying delivery of those through 29 different budget action plans. So, as you've said, Councillor Scopes, at period 2, which is the figures from May, we are projecting an overspend of £9.2 million in the adult social care element of the adults and health budget. And in the main, this is made up of two parts. One is around the increasing demographic and demand pressures and inflationary cost pressures, so pressures that are coming from the market in terms of the size of packages, cost of packages and cost of placements. And then also a really quite significant part is around the under-delivery of 3 of our identified budget action plans. So we're profiling for the year a year position of 9.2 million. This will change, it inevitably changes month by month because we're not at standstill. We're commissioning new packages of care and support for new people coming to us. We're expanding and increasing the size of packages. And at the same time, we're progressing our budget action plans for the delivery of savings. So the trajectory will and the projections will change from period to period, and that's why we have to do a monthly reporting. But just a little bit around what we're doing, if that's okay, around these budget pressures. So I've already said that our demand pressures are relating to people requiring care and support, be they working age adults or older adults, either living longer and needing support for a longer period of time, being placed in care home setting for a longer period of time, living with multiple long-term conditions, and therefore requiring both larger packages and additional placement costs, but also for a longer period of time, and also people being placed in residential nursing care, which always costs more, also being a trend which we have seen increasing. So overall, on that demand pressure side, we're forecasting 3.1 million demand pressure. At the start of the year, this was 5.6 million, and I'll come back to that point in a bit. So what that demonstrates is that actually we've got an improving position around demand. We are really managing demand through our budget action plans. So where we started the year, actually it was 5.9 million, sorry, not 5.6. We started the year in April with an overcommitment against our budget of 5.9 million. For period 2, we've reduced that to reporting an overspend position of 3.1 million. So it's going in the right direction, but there are remaining pressures there. In terms of then the remaining part of that 9.2 million, the bulk of that is around the under-delivery of 3 of our budget action plans. The biggest of those is a reduction in income, and that is a £6.1 million shortfall. That constitutes 6.4 million of client contributions, so people who are eligible to pay for their own care and support, either in entirety or contribute to that. We have a target of generating income through charging, and what we are seeing is that that is dropping off. We reached quite a high level mid-year last year, and then from the tail end of last year we started to see a drop in our income being received. And this is not unique to Leeds. We are seeing that people's capital and their assets are depreciating, partly because they're living longer with multiple conditions, needing services for longer and therefore having to pay for services longer. It also includes people who are self-funders who have paid for their care and support in entirety, coming to us and saying that their assets have dropped below the £23,250 threshold, and saying they've eroded all of their own income and their assets, and it's dropped below the threshold, and now the council is required to pick up paying at least part, if not in entirety, their care costs. And you will probably know that people who fund their own care, they get charged in higher levels, particularly if they are in a care home setting. Sometimes their costs are 500, 600, up to £1,000 a week more than if they are local authority funded. Some care homes, a very small number, really charge a premium, and therefore it erodes people's own assets much, much earlier. So we're seeing that not just in Leeds. Many local authorities are reporting quite a significant drop in income received from people's contributions. So that's one of the most significant budget action plans that is not set to deliver in the level of income that we were hoping for. The other, in the main, is one of our providers, our largest learning disability provider. You'll recall that we had a discussion about that particular provider at the last meeting at the closed session. There is a savings target attributed to that organisation around just reconfiguring some of their services and ensuring that they're improving the efficiency of their services. That's a 1.5 million savings target, which, due to various circumstances, are now not going to be realised. We think that that 1.5 million is at risk. And then there is further slippage in relation to passenger transport. We've got an £800,000 in-year savings target by trying to reduce the increasing costs of passenger transport. This happens in adults and in children's as well. Our cost for passenger transport is in the region of £8 million a year. We had a savings target of 800k. We think that we will deliver those savings, but probably not all in year. So we're anticipating a 400k slippage there. So that's what makes up the 9.2 million. I'm really pleased to say that we have got, out of the 29 budget action plans, we've already successfully delivered on quite a significant number of them, and are projected to deliver or even possibly over-deliver on some of the others. So that £36 million savings target, in the main, we hope that we will realise, with the exception of those three that I've just mentioned. So we're taking quite a prudent approach in forecasting, because we know that the pressures will continue through the course of the year. But at the same time, we're working with our care and support providers, with the market, to try and manage their cost pressures. Again, last month we talked a little bit around, actually we had a specific call-in, didn't we, around fees that we're paying providers, and the providers came to us and said, we can't manage our home care, can't manage with a 1.6% fee increase. We had to therefore go to corporate reserves to secure a further £3.7 million out of the Social Care Reform Fund to allow us to pay our home care providers 5% increase rather than the 1.6%, and we maintained the position with the care homes at 3.5%. But they are still coming to us and they're saying that their costs are increasing significantly above the amount that we've allocated to them, not least because of increases in the national living wage and the employers' national insurance contributions. So that noise hasn't gone away. The market still is saying to us there's a shortfall in funding. So we're mindful of all of those things, and we're working with the providers around that position. So I just want to provide some assurance that there is really stringent governance around our oversight of the budget, not least because we've got an oversight board, a financial oversight board, which is chaired by Councillor Cooper, whereby we talk through all of the savings proposals that we've got and the work we're doing around demand management as well. We're also working with Newton to really help us around prevention and really trying to scale up how we might be able to put more around prevention so that we can stop people coming to us and needing care and support because we signposted them and we get to them much earlier than when they hit crisis. And some of that work is already beginning to show dividends as well. It's really timely that just this week we've had the ADAS Spring Survey. ADAS is the Association of Directors of Adult Social Services, whereby all 153 directors of adult social care and their senior teams and their finance leads are asked to complete an annual survey. This has been running for several years now. This survey has just been published and it's very clearly showing that 80% of the directors that responded, so that's 136 local authorities responded to the Spring Survey, and 80% of the directors said that they have started their financial year 25-26 with an overspend position. We are one of those local authorities, and that as a result of that overspend position, we are therefore having to not only start on a negative basis in the financial year, but also then having to recover that position by generating further savings. The report also shows that many local authorities, the majority, are reporting concerns about their ability to retain a balanced budget in year. By far the majority are saying that they're likely to overspend in the current financial year. Now, I'm not saying that therefore, we're not alone in this. I just want to make sure that you're aware that there is a significant financial pressure across the country on local authorities. It's reported for children and families, but it's now in the last 3 years been the case for adults as well. It hadn't been historically because adults had loads of different grants, government grants. Those grants have all been reconfigured into one or two single grants and have not increased in line with cost pressures increasing. So overall, over the last 3 years, many local authorities are experiencing what children and families have experienced for some years, i.e. budgets that have been set that don't cover their actual cost pressures. So that's where we are, but again I want to provide some reassurance that we are working our socks off in the Directorate to try and overcome some of these cost pressures, but I'm happy to take any questions.
Thanks for that, Caroline, that's really helpful. I open up to questions from anyone who has questions. Councillor Bromley.
Thank you, Caroline. You mentioned cost pressures changing over the last 3 years, am I right? So in terms of those cost pressures, what is that pressure in particular?
A big chunk of that is the market. The market is seeing, through absolutely good reason, increases in workforce costs, pay, terms and conditions, a real push on not just the national living wage but the real living wage. More recently, employers' national insurance contribution hikes, which are providers are saying, well, the council is the main customer, buys most of the services from the providers. How on earth are the providers going to absorb those additional costs if they're not met by the councils? So a big part of that is cost pressures from the market, inflation-related costs, and in the main workforce-related. bearing in mind that most of the providers, their biggest costs are their staffing budgets, and they're saying if costs increase by way of wages to staff, improved terms and conditions, then where are they going to be able to cover those costs? And one of the things that is going to emerge, it's not happened yet, but we will hear from the market very soon about the changes that are happening around the Employment Rights Bill, which is going through the process of legislation, and also Angela Rayner's commitment to the Fair Pay Agreement. If those things get put into legislative requirements, if there is legislation to support the Employment Rights Bill, it becomes an act, and if there is a requirement for providers to enhance their pay and terms and conditions for their workforce, then the providers are going to say, well, we expect the local authority to cover that cost. And if that funding isn't budgeted for, which at the moment it isn't budgeted for, then the local councils are expected to cover those costs. So that's one of the biggest. And then the other cost pressures are around demography, an ageing population, living for longer with multiple long-term conditions, and complexity of need as well. And then there's also changes in the NHS, huge pressures on people who receive care and support through continuing health care, and there's a massive pressure on the NHS budget, which many NHS organisations are saying we can't afford to continue to pay for people's care because it's free at delivery for people who receive services, whereas if social care people have to contribute to it. So the NHS is saying we've got to really sharpen and narrow the number of people getting continuing health care. Well, those people are still going to have care and support requirements, and then that's going to be pushed to local authority adult social care budgets. And again, a very national picture emerging around local authorities saying that by default, through no fault of their own, as the financial constraints are tight for the NHS, that pressure is being passed on to local authority social care budgets.
Thank you. Do you have a supplementary? No, great. Okay, Councillor Ritchie.
Thank you. I think it's really helpful that you've explained the income dropping description, because that to me conjures up people not paying the bills rather than what's actually happening. From what you're saying is the eligibility for support is increasing, so our costs are increasing that way. I think that it's important you've made that distinction, and it's very helpful. I'm hearing again it's through limited casework that there may still be issues with our billing process. I know we've introduced a new system, but is that adding to that shortfall in some cases? And the other thing around the passenger transport review, I was at Learning Disability Partnership Board this morning, even though I'm no longer disability champion. You wouldn't know that from my workload since giving that up. And it was about transport, and I was surprised to hear how few adults are being put through travel training, and that sounds like there may be a capacity issue around that, and if that's one of the drivers, we should be investing potentially to save. And just for members' information, around 2/3 of those who start travel training successfully complete the course. So it is an option for those that it's available. There are other opportunities you'll probably be aware of, that Advinet have got a 3-year contract around travel training, and they have committed to work sort of partnership-wise with the council to try and hopefully relieve some of that pressure. Thank you. That's it.
Thank you very much. Yes, I'll come back to both points then. In terms of the new billing system, the automated billing system, actually that's what has helped us over the last 2 years to really recover people's contributions in a way that we were not doing before. That automated billing means that people, we're not relying on manual processes of invoicing month by month by month. It automatically goes out to people. It does generate concern and complaints because some people will say, well, I've received my bill, but I didn't receive service X or Y or the full hours. So there can be some toing and froing to make sure that, you know, the billing is accurate or is amended to reflect people's changing packages from week to week, month to month. But overall, the new automated billing system is what has helped us to really increase our income. So we're really pleased with that. And most people are actually reporting a positive experience because they get their bill in a much more timely way than they used to. Because it doesn't take so long anymore, it's just an automated process. So they can see, oh yes, this is my bill for this last month, as opposed to I've received a bill in the post and it relates to 3 months before. So we're getting some positive feedback, but there will be people who will say it's not accurate, and therefore there's a little bit of negotiating around, okay, and calibrating what's owed. But overall, that is helping, not hindering what we collect. In terms of passenger transport budget savings plan, we've got about 8 different lines of projects around how we could reduce our cost on passenger transport, and travel training is one of those. And absolutely, I would concur with you that there is probably opportunity to maximise that opportunity more. There is resistance. We do find families quite resistant to travel training because they think, you know, their son or daughter, adult son or daughter, needs that transport, needs escorted transport, because it's not just passenger transport, it's people who then need somebody with them to help them, you know, to be with them on the bus, etc. Some individuals need 4 seats rather than 1 seat on passenger transport. Some people need specific taxis. So wherever we can do sort of independent travel training, there's a real opportunity there. But that is one of the areas that we're absolutely looking at. I will take back whether there's actually an issue around adequate levels of resource in travel training. Have we got enough people around to support people through travel training? So I've made a note of that because that's a further sort of area of inquiry that we will undertake.
Thank you for clarifying the billing issue. I did caveat that it were a very small sample of casework, but you've explained exactly where we are, and it's good to know that is helping with getting the income in.
Thank you. And then Councillor Blackburn, and if anyone else wants to comment, please indicate now.
Thanks, Chair. It's on demographics. If I heard you correctly, you said that you were running with a larger increase in first month, and then you managed to cut back in second month. Is there any likelihood that can be reduced over coming months?
We're absolutely hopeful. So yes, we started with a 5.9 million projected overspend because that was our commitment at the end of the last financial year relative to the budget that we've set for the current year, and that was on demand. And we have been doing work such as reviewing. So we've put more social work capacity in, and we've put more occupational therapy capacity in to help us reduce our spend on agency staff, but also to really focus on reviewing activity. So people who have been receiving a home care package, for example, for 3 years, 4 years, 5 years, reviewing them and saying, well, you needed a big package before. Can we work with you to reduce the number of hours of care that you need? Instead of having 2 carers, can we use equipment that helps you then to only need 1 carer to transfer from to get you back into bed, etc. How can we work with you and your family and carers as well to reduce your need for paid for care and support? So yes, we've successfully reduced that, and we've got a number out of the 29 budget action plans. Our biggest consolidated budget action plans are about demand management in the region of about 12 million, made up of different sort of projects and programs of work, and they are beginning to see really good impact, and we hope that we will be able to manage that 3.1 demand pressure down, fingers crossed.
Super. Thank you very much for that, Caroline. I really appreciate you coming and giving us an update there. And so with that, I'm going to close that item. Thanks, everyone. So I'm going to close today's meeting. Just let you know that the next scheduled meeting is on the 9th of September at 1:30. I'm sure it's in your diary. I hope everyone has a lovely summer break if they're having a break. Take care.